How's it going, guys? So this question, exceedingly high yield for pediatrics for 2CK, as well as pathology for step one, okay? So I won't waste our fucking time. I'll just hop right into the high yield points, but I will be a quick asshole and tell you to subscribe to my channel. I really appreciate it. And hit the like button. I really appreciate it. And find me on Instagram at melman_medical, MEHL_medical. Link is down below. And find me on Telegram. Links are also down below. Now, hopping into the actual fucking question here. We have a male neonate born at term to a woman 28 weeks gestation. The fuck am I saying 28 weeks gestation? 28 years old, he was born at term. I'm not going to restart the whole fucking clip right now, am I? Uncomplicated pregnancy, vaginal delivery, heart sounds are auscultated on the right, so we have dextrocardia. Instantaneously, many students will be thinking about Cartaginer syndrome, aka primary ciliary dyskinesia. It's not the diagnosis here, but we have dextrocardia. Ultrasound shows absence of spleen. Okay, Howell Jolly Body's nuclear remnants, classic finding on a smear seen in patients with asplenia. Question is asking greatest risk of developing which of the following. So this is Ivermark syndrome, Ivemark syndrome. You do not need to know that name / eponymous term for USMLE. Don't worry. I'm just telling you this shows up on the Pediatrics NBME. You can answer this question without knowing. This is called Ivermark syndrome, OMG. Okay, I'm just telling you what it is when you have dextrocardia plus organ anomalies such as asplenia. So the question's asking what we're most likely to see in this patient, what he could end up developing. Choice A, autoantibodies, wrong fucking answer. I mean, there's no reason to suspect autoimmune propensity here, okay? I mean, they're not talking about autoimmune disease in the mother, nothing like that. It's just a very vague general answer that would be a distractor for students who don't know what's going on. Choice B, macrocytic anemia, also wrong fucking answer. When we talk about pediatrics, congenital conditions, you could think of conditions such as OMG or orotic aciduria. Holy shit, that can cause macrocytosis. It's not the case here, okay? I mean, we do not have orotic acid described, and but just in general, macrocytic anemia, of course, B9 folate or B12 deficiency or alcoholics actually can get macrocytosis. Microcytic anemia, also wrong fucking answer. I mean, when we talk about pediatrics, thalassemia, okay? It could be iron deficiency anemia and celiac disease, or also in kids who consume greater than 24 ounces of cow's milk daily, generally under the age of 2. That shows up in pediatrics. Also hereditary spherocytosis, microcytic anemia. Wrong fucking answer, as I just said. Choice D, sepsis is a correct answer. Now, this is very high yield. You need to know asplenia, okay? Whether it's sickle cell, where you get autosplenectomy, or whether you have some weird syndrome called Ivermark. If you have asplenia, you're at risk of encapsulated organism infections, okay? So strep pneumo, Haemophilus influenza type B, Neisseria meningitis. The spleen is where 50% of the body's reservoir of macrophages is. So has high phagocytic capacity. In order to clear out encapsulated organisms, the immune system's two major opsonins, C3b and IgG, will bind to the surface of the encapsulated organisms, and then they're cleared out by the macrophages in the spleen. We lose that capacity. So sepsis, especially strep pneumo, very fucking high yield for 2CK, all right? So you need to take that one to the bank. Choice E, thrombocytosis, wrong fucking answer. You should know the difference between essential thrombocytosis and reactive thrombocytosis. They will give you a platelet count of, let's say, 1.4 million, and you're like, what the fuck, right? Because platelet count should be 150 to 450,000 per microliter. If they get a JAK2 mutation, if they give you pain in the fingertips, that is suggestive of thrombocytosis, and they'll tell you bone marrow biopsy shows megakaryocytes, okay? High levels of megakaryocytes, that's essential thrombocytosis. Reactive thrombocytosis would be in a setting of infection, and you would not have megakaryocytes, excessive megakaryocytic proliferation on bone marrow biopsy. You know the deal. I'm going to continue making more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.